Good morning, everyone, and welcome to our May 2022 EHE Regional Learning Collaborative session on addressing the HIV epidemic in Asian and Pacific Islander communities. My name is Elena Rosenberg-Carlson, and I'm the EHE coordinator here at the UCLA Center for HIV Identification, Prevention, and Treatment Services, or CHIPTS. For anyone who might be new to the Learning Collaborative, our purpose is to facilitate knowledge sharing and support collaboration and collective action across California's 8 EHE Phase 1 counties, and to really work to accomplish our shared EHE goals. We also welcome folks from outside these 8 counties to join the sessions and learn together with us. So welcome to everyone on the line this morning. Some of you are already using the chat function to introduce yourself, which is great. Please do take a moment to send a message to everyone in the chat with your name, affiliation, and location. Next slide. So in honor of National Asian and Pacific Islander HIV/AIDS Awareness Day, which just passed on May 19th, this session will focus on tailored strategies and approaches to address HIV in Asian and Pacific Islander communities here in California. Today's session will feature 2 amazing presenters, Nan Ding and Dr. Wei-Ti Chen. As usual, please feel free to submit questions at any time during the session using the Q&A function on your Zoom control panel. We'll use the Q&A function to collect questions throughout the session for the live Q&A at the end. We'll also keep the chat function open in case you'd like to share comments or resources with the group at any time. I also want to note that we are recording the session and we'll post the recording and slides on our EHE Regional Response webpage within the next week. So now I'm excited to introduce our first speaker, Nan Ding, Director of Clinical Quality Management Development and Behavioral Health Counselor at APAIT. Welcome, Nan.
Hi, everyone. Should I go ahead?
Yeah, you can go ahead and share your slides.
Hi, everyone. My name is Nan. I work for APAIT. We are a division of special service for groups here at Los Angeles. So for APAIT, we have 2 locations. One is in Los Angeles, Vermont, and Wareshare, and another location is in Orange County, Garden Grove. So before I start, I just want to say thank you for Elena and Enrique who organized this whole webinar to share during API Heritage Month. And I'm sharing this Chinese proverb, isn't it pleasant to have friends come from afar? So in Chinese culture, it's always a pleasure to meet new people, to learn new things, and to share each other's story. So I'm really, really happy that CHIPTS provided this platform for me to share something that APIAT has been doing to this community. So this is a brief agenda about my presentation today. I'm gonna start with a brief organizational overview about APIAT and a very short data overview and what APIAT has been doing in terms of HIV prevention and treatment, and how do we address mental health and housing, and some actions we have been doing, and some lessons learned throughout the course of our journey here. So for APIAT, we were founded in 1987 as a grassroots AIDS service organization here. At that time, mainly for API individuals who were experiencing HIV/AIDS epidemic and dying along from AIDS-related stigma and shame during the peak of the epidemic. And we started off as a peer support counseling group, and now we expanded our services to not only API community, but also general vulnerable community experiencing behavioral health challenges, housing insecurities, shortage or with community resources. So we developed to be a more comprehensive organization serving a wider population, but also immigrants, refugees throughout this 35 years. And this is a brief overview about Asian Pacific Islanders and HIV related data. As you can probably see here, APIA population constitute about like 15% of overall Los Angeles County population. And about like 4% are living with HIV and AIDS in LA County. And this number is relatively low due to stigma, and API community is least likely to get tested for HIV and to report HIV status because of stigma and confidentiality and the multiple issues that the community is experiencing. And we do have a significant amount of LGBTQIA2S population among our API community here, but only about like 20% individuals have tested for HIV. So the number is relatively low compared to other race ethnicities. And I was doing my research, and as I was preparing for this presentation, I did a brief Google search. I literally typed HIV care in Google, and all the red arrows are services available when I type HIV care. And we can see here most of the services, HIV care services, are mainly in west side and a little bit down to the south side, and not really, we technically don't have services available, HIV specifically on the east side. But if we look at this demographic map, which is a little bit outdated, but it's very specific. It's for Asian API population. And on the east side of LA County is has the most API population. And in the last decade, Asian American population in county grew 20%, and Pacific Islander population grew 9%, and the total population grew only 3%. And Los Angeles County is almost the capital of Asian America, with the largest number of Asian immigrants of any county in the nation. And some example of neighborhood in the east side of LA, Monterey Park is the largest percentage of Asian per capita at 68%, and Arcadia is the highest percentage of Asian American population, has the highest percentage of Asian American population growth at 38%. And I'm just gonna stop here for the data, but we will come back with those two maps. And I will continue with what APAIT has been doing in terms of HIV prevention and education. So we have HIV Storefront at our both site. We provide free, confidential, and rapid HIV and STI counseling and testing services. And we do from Monday, Friday, and we have very flexible hours. So we basically provide 12 hours for HIV testing services. And that's designed because we found out a lot of individuals, they have stigma coming to office to get tested during normal business hours. And we actually have an increased amount of individuals who come after hours in like quiet hours, and it has been working very well in terms of our HIV storefront testing. And this is, we also provide HIV mobile testing unit. We do rapid HIV and STI testing on the spot when we go to the community. We are an organization that we have a lot of activities we have a lot of outreach activities, and we go to the community and we participate in a lot of events like prides, bar, and we go to like LGBTQ friendly bars and clubs to engage with our priority population who may not find, storefront be their priority or a convenient choice for them to get tested. And our MTU has been a very successful strategy. For example, normally in the previous Pride event, sometimes we could get like 400 tests one day during a big event like Pride. And we have also HIV and STI prevention and education services here at APAIT. We have G-Spot, which is a sexual health education for gay, bi, and queer male identified individuals. And we also have Queer Asset, which is a life skill workshops for that population. And for G-Spot, we provide sexual health education, like how to have safe sex. And we also provide safe sex kit. And this is something that we have been doing. It has been very successful, and it's primarily for younger adults. And for Queer Assets, it's a life skill workshop that people learn like how to build resume and how to access community resources. And both groups serve as a platform for LGBTQ individuals to build connection and to prevent social isolation. And during the pandemic, thanks to the technology, we actually shifted this to telehealth, and it has been very successful, and it has such a positive impact during the pandemic when everyone is during lockdown. And we have so many, like we hosted a lot of online activities for those groups. And we also have Midnight Stroll, which is outreach, monthly outreach that we actually go to homeless hotspot, and we provide them with basic necessities and resources available at APIT and in the community. And this is outreach like we do on social media about HIV testing. It doesn't have sound, but it's one of the example that how do we tailor our outreach strategy and to our population. And we posted this video on TikTok, and so far I think it received over 350,000 views, and people actually slide DM to us and actually ask for services. And thanks to social media, we also have people ask, not only from Los Angeles County, but also from other states. So this is something that we are very proud that we're doing this for the community. And this is a brief video about our menstrual outreach. . 。  . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 。 . 。 。 。 。 。 . 。 。 。 。 。 。 。 。 。 。 。 。 。
。 . 。 。 。 。 。 。 。 。 。 。 。 。 Today we're getting ready for Midnight Stroll, which is when we go out to the community and pass out food bags and different resources. So right here we have everything set up. We're about to make food bags with sandwiches, snacks.
The Midnight Stroll is a after-hours outreach program that goes out in the streets of Hollywood and greater Los Angeles to provide basic necessities for folks that are experiencing homelessness.
Today's Midnight Stroll is an opportunity to meet our homeless brothers and sisters, and in particular those who are transgender women, and help them with services and aid and care kits.
Today we're giving out 80 food bags, so hopefully we get to meet 80 new folks today. We're going to be going around the Hollywood area.
We can invite them back to our offices if they so desire and provide them with HIV testing, STI testing, mental health counseling, housing. We have housing opportunities for them. In the heart of the pandemic, or in the midst of it, when it was at its height, people really were in need of the services. And the fact that we were able to provide those services was just fulfilling.
And this is an example that day we went to Hollywood to provide services, but we do different neighborhoods. Sometimes we do Echo Park, sometimes we do MacArthur Park and downtown LA. And it has been very successful, and we have been doing that for 5 years with this outreach activity. And this goes to our next portion is mental health services here at APAIT. So this is a brief overview about like API and API population and mental health services. So overall, API individuals have the lowest help-seeking rate for mental health purpose of any racial ethnicity group. We have around like 23 API individuals with mental health conditions are receiving treatment, and almost 33% of Asian Pacific Islander individuals are not fluent with English. And this is a infographic about there's like around 6% US population are API individuals, but only over 15% reporting have a mental illness. And this is over almost 3 million of our overall population here. And there are some like general feedback in terms of why Asian individuals are not more reluctant to reach out for services. And those are the 4 most common ones mentioned. People don't want others to find out. There are confidentiality concerns, and there's the fear of neighbors' negative opinions. And of course, there's language barriers. And this is the individual therapy services that we provide here at APAIT. We have DMH and we have Red and White for people who are underinsured or do not have health insurance. And we also have SAMHSA program, which is a combination of tackle HIV services, mental health, and substance use issue. And this is the short-term services for SAMHSA, maximum 6 months. But our goal is to always introduce them to DMH throughout the 6 months so that they could have a more long-term services. And all those services are available in Mandarin, Japanese, Korean, Tagalog, and Vietnamese throughout APAIT. And we also have group therapy with our day room. This is our agency's longest running program. How we started this presentation when we introduced APAIT, we started as a peer counseling group, and this is one example of our monthly calendar, like what we do every day. And we also have an API plus groups for HIV positive individuals. It's called Positive Vibes. And this is also, the group therapy is also available in different languages. And we also have a prostitution diversion program. We do not like how the name sounds because it doesn't reflect our population, but it is a program that is a court order program, and the primary population is API, monolingual API language speaking cisgender female, and they all work in massage parlors, and it's 8 courses, and we include HIV prevention and education services to the curriculum, and also HIV testing for all the individuals in this program. And the last program we're going to introduce is our housing programs. We have 4 housing sites at APAIT. 2 of them is bridge housing, which is Auntie Mally House and Casa Zuma, and another is 2 permanent housing, Sarah's Place and Rampart. And for Rampart, it's a permanent housing for HIV individuals who have also substance use disorder. And for all the 4 housing sites, we have case manager, mental health therapy on site available. And we also provide hotpot services for individual at different spa areas here in Los Angeles County. And this is the last section of my presentation. I want to share and also hear the group's feedback on how to increase our awareness, our strategy, and is there any actions? And as I was preparing for this presentation, I thought about my personal experience about 1 month ago when I went to a clinic. It's a very well-known clinic, and it's in the west side, and I was filling out the form, and when it comes to race, and it kind of surprising to me that I don't know where do I belong. There's no box for Asian population, and I had to just write Asian under this race box for myself. And I found this very interesting, so I just share this on social media, and this is just a couple of feedback that I received from my community, and I have a conflicted feeling that I don't know, having people share the same experience. Well, and we are talking about how do we bring awareness to API community, but when we are in a community clinic, that at the first step, there's no sense of belonging there. And that brings back to when we started this conversation, is when we are talking about strategies, but we don't have services available at our population that we tend to serve. And this is something that APIT is so proud that we have this MTU services. We can drive around, we can go to the community, and we can participate in St. Gabriel Pride, and we participate like multiple events, you know, during this month. And I have a friend that she works for a medical clinic on the east side, and it's a challenging situation for her to refer her client for HIV related services there. And in order to bring awareness, and to engage with our population. APIT is very big on our social media reach, and almost every month we create some social media posts to reach out to our API community. And we have this mentioning the authors and how to address mental health awareness. And like during Lunar New Year, we share the traditions. And we also invite community advocates like Kelly Hu, like Mapa, to talk about their mental health journey during the Mental Health Awareness Month. And we also created a social media campaign for API HIV Awareness Day. And to address the current Stop Asian Hate climate, we also share this pamphlet with our population about how to report a hate crime. It has a step-by-step map for people to report a hate crime and how to protect themselves. And we always reach out to community like artists who represent our API community, and we share their work. And I think the key for us is we are consistent with our social media engagement and outreach activities. And the last 2 slides is some lesson learned when we survey API population is just surprisingly, transportation is one of the most mentioned barrier when we reach out to our client. So we provide Uber and Lyft, and sometimes we provide company van to pick up our client. And we have multiple API languages available at APIT. We are also fortunate to have one of the division PALs provide additional translation services if we don't have that services, we don't have the language capacity in-house. And also we have mobile testing unit and community mobile clinic, that's how we call it now, to reach out to community who may not come to our office location, who may not find it convenient to visit in person. And we have been very consistent with our engagement, our outreach activities such as social media, and our senior management is very aware. When we hire our staff, we have a good portion of Asian language speaking staff here at APIT. And we also work with many community organizations. We are part of the Asian Pacific Islander Human Trafficking Task Force here at Los Angeles County. And we are also collaborating with China Trans Youth Crisis Support Network. It's the only network that supports homeless individuals in China. Last week, we just had a communication with one of the leaders in that organization. And we also work with local business, and at APIT, we have a community liaison, and we provide training to different community organizations. And we also remind our staff, we have training about implicit bias, and it's a consistent learning curve in my perspective. It's not only during the API Heritage Month, it's not only during the Mental Health Awareness Month, it's every day we may have to reflect, we may have to ask ourselves the question, and so that we can make progress every day. And I think for me, if I put on my clinician hat, as a licensed social worker, I'm a true believer for whole person care. I think when API individual coming for HIV services, they're also coming for transportation, they're also in need for housing, they're also individual experiencing fear because all the Asian hate crimes happening. So I think that helped me a lot when I see where the person comes from. And those are some brief resources that help API individuals here. And as I started with the Chinese proverb, I'm gonna end it with a Chinese old saying, a journey of 1,000 miles begins at one's feet. I think today it's one step that we make to learn different resources, to share feedback and experience, and collectively we will make a big progress, and we will further support our API community here. And that's all for my.
Great. Well, thank you so much for your wonderful presentation, Nan, and also really for sharing your own personal experiences with us of, you know, not always feeling seen or having a sense of belonging, and how you've been treated also in healthcare settings. So thank you so much again. I already see a few good questions coming in, and just want to remind everyone to please submit questions to the Q&A box at any time. We'll work on answering some of your questions directly in the Q&A box, but we'll save most of them for the live Q&A at the end. And now I'm delighted to introduce Dr. Wei-Ti Chen, Associate Professor at the UCLA School of Nursing. Thanks for joining us, Wei-Ti.
Hi, nice to meet everybody online. And my name is Wei-Ti, and I'm a faculty at School of Nursing, UCLA. And then I'm very, very delighted to have a chance to share my journey with everybody about how we do and come to now working with API, living with HIV. Currently, there are not that many researcher focuses on this area. So this is just only a very small project starting, and then we are kind of forged into many, many publications. So here are what we learned. So Asian Pacific American living with HIV are not doing better than other people of color living with HIV compared to Alaskan Native Americans, or compared to African Americans or Hispanic Americans. APAIT are not really doing better, but it has been long remained invisible in the scientific literatures, and you really rarely see any Asian Pacific Islanders Americans HIV reported. So just like Jing Nan reported, Asian Americans tend to cluster in major metropolitans. San Francisco is one of the biggest one, Los Angeles, New York City, and Philadelphia tri-state area, and Washington, D.C. Asian Americans perform well on health indicator compared to its other racial minority. However, is one of the highest growth rate nationally, and with more than 80% of new infected in Asian American men, particularly with MSM populations. And even though there are HIV and positive, and compared to the rest populations are low, however, 1/3 of the Asian American who develops AIDS within a very short time after being diagnosed. That means that those people who doesn't know they are HIV positive, but until they really have developed full-blown AIDS and end up in emergency room. And from our research participants, a lot of them are really end up in emergency room and then stay in hospital for 1 or 2 months until all the symptoms has been subsided, and then kick back to the community. So that is really one of the tragic events in our Asian American living with HIV. And Asian Americans did not differ from Hispanic African American in access to retention in HIV care, especially result in low viral load suppressions, about 54%. Asian Americans are the major racial groups that most frequently seek romantic partner outside their own groups. So it's one of the things that you can think about. Asian Americans and especially MSM, mostly they are dating not Asian Americans. So the underlying thing that we are thinking that it might be also have this chance to spreading the HIV because they don't have the chance to get tested early, or don't get into the care early. So it might just getting into one of the reservoir into the community that we just don't know. So talk about acculturation. Many of the Asian Pacific Americans with HIV are immigrants. Acculturation stress are intertwined with racism and HIV stigma that Jing Nan already mentioned that it has been one of the biggest stigma in this population. So it does shape their mental and behavioral health into the with HIV at the same time. So APAIT perceived stress can mediate the relationship between acculturation and depressed symptoms. So for those HIV positive immigrants, Asian Americans immigrants, that they suffer from depression and at the same time the acculturation is all intertwined. One of the paper we wrote is that for people who has higher acculturated has less depressed symptoms is related to HIV. So it is quite interesting that when we see those immigrants population with HIV, especially Asian Americans, that is also one of the key issues that we need to focuses on, that they are depressed symptoms. And many of them do come to United States with American dreams. And after they decided diagnosed with HIV, it has broken their American dreams, that those reshape their own self-identity and self-actualization is one of the critical things for them to reshape themselves. So acculturation has a positive total effect on patient healthcare provider relationships, which can be mediated with stigma and stress. That translated into our lay languages, that means that people who has better acculturation can know how to and access to the U.S. system, medical healthcare access. They have a better relationship with healthcare provider, then they have less stigma and less stress. So it's quite interesting that whether we can help them to acculturate into the society will also help them to decrease the stigma and stress. So acculturation is very beneficial for patient healthcare provider relations to the extent that they can decrease the stigma and stress. So talk about family, because Asians are really seeing the family supports as one key thing as a collective culture background. So family can assist those people in coping with HIV-related stress and help them to on the everyday life. And for those Asian Americans with HIVs, hesitate to disclose their status to family member and friends can until no longer be hidden. So which means that if they prefer or plan to disclose, then they will gain the family support. So the family support can help them physical and mental health, decrease self-isolation, and better access to HIV care because of the networking and higher antiretroviral therapy adherence, reduce risk behavior, and because of this family member helping them to enhance their quality of life. However, family is also one of the stresses that we can see, because after disclose, stigma from friends and family members are very frequently discussed. Asian MSM experiences pressure to marry, a very strong expectation in Asian society that you don't quite see those in the US, you don't quite see those MSM are still married. But when you go to the Asian populations, that even though back to Asia, those MSM usually do have a wife and do have a family or a child, because the culture expectation. And for those people who are HIV positive, who are single or married without child, the family can also become another additional source of stress. And for those children who are whose parents are HIV positive, and not just only providing physical and psychological support, but also serve as a translator and liaison for information support in the hospital. So it's quite interesting that when we see those cases that are disclosed to us, that their children are helping them to translate it inside infectious disease clinics. At the same time, they also need to disclose how they get HIV in front of the children and while in the clinic talking to the providers. So it's very, very tricky situation. For those HIV positive women with Asian backgrounds, usually they have experienced higher intimate partner violence, because those people are thinking the men usually think that their wife are not loyal to the family. So it does have higher chance to experience that IPV. So talk about stigma and mental health. HIV is a disease associated with very large amounts of stigma and other taboo among Asian Americans. Doesn't matter whether how the transmission routes. Usually when they think about HIV, it's a dirty word attached to it. So it does connect with homosexuality, substance use, and promiscuity, particularly in Asian populations. So including MSM population, they suffer from shame and self-stigmatization. So MSM is mental health, is we need to focus on more on mental stress and see whether they are screening, whether they are experiences any PTSD or stress or depression during the time that when we have visits. And many of those people are struggle with disclosure of their sexual preference and HIV status to their family member, especially for those men who tend to experience a higher level of depression. One of the projects we conducted in China that helping those HIV positive parents to disclose their HIV positive status to their children. In the end, that we changed the study aim a little bit because there's no way we can force them to disclose, but we can help them help those HIV positive parents to be ready if they're whenever they are ready to disclose, and they know how to disclose. So there's no end days when or how they are disclosed, but we can help them to prepare that until they are ready to disclose. So to talk about religions and spirituality, religions, particularly Christianities, does traditionally associate with belief and doctrines that are antagonist toward groups at high risk for HIV, especially that's homosexual and those who are sexually promiscuity. But interestingly, with Buddhism that we know in Asia, many countries or many peoples or Buddhist backgrounds, especially like Thailand or Burma, or in China or Japan. The principal beliefs are focused on karma and reincarnation. Both may factor into self-management and self-advocacy. So that means from our study shows that people who see that if the God treating them nicely and just give them a big task in this life, and so they might have better care engagements with healthcare providers and that treat themselves better. So in order to have a better reincarnation next life, in order to have a better next life. But for people who are seeing the religions or the God treating them not so bad, or they see the God give them a task that treat them badly in this life, they have a worse connection with care engagements, that they will might miss the appointments. They don't see that why the God doesn't take care of them. So they do have the worst quality of life compared to those people who sees that to have the positive religious beliefs in this situation. So worships and meditations and mediations can decrease the internal stress and enhance their immune system. So far, the understudied areas is one of the hardest to recruit populations with Asian Americans who are HIV positive. Intervention aims and improve immigrant and healthcare provider relationships are really lacking. There are limited studies to support the development of such intervention. How to help those Asian Americans and or Pacific Islanders Americans to engage with healthcare providers are really lacking. Coping with HIV, sleep disturbance, and physical symptoms are also potential factors or intertwined in each factors. Roles of family support in APAIT care and health engagement, especially these areas that we should focus on, like a physical, psychological, spiritual, informational, social, and practical social strategy, should be explored a little bit more. So for future directions, mental stress, for example, stigma, social and religious commentaries, and guilt should explore a little bit more, and addressing the the mental health aspects of HIV for acquiring the disease play into the life of those affected. So from the studies that we have conducted back in China, it's quite interesting that the parents who are HIV positive, they don't really need to disclose how they get it. Usually they can just get away with the questions that they're talking to their children that, oh, when I was young that I did something crazy, but I just want to make sure that you are not doing the same, making the same mistakes as me. So usually they can get away with how they get HIV, especially those MSM. But at the same time, they can still keep their own respect from their children. Religions could bring peace of mind, but reaction many participants got from church temple member also hurts them. So which means that when those people who are practice religions or go to the church or temples, after the churchgoers know this person's or HIV positive, the reactions or the feedbacks from the churchgoers usually hurts them a lot, because they are feeling that they are isolated, especially in the very minor behavior, for example, sharing foods or sharing drinks. That kind of things also hurts them though. So a lot of them were decided not to stay for those gatherings, but just only attend for worships. HIV status, immigrant status, family relationship, Asian American identities that we that Dean just mentioned, and religious support or disapproval from society should be also studied. Accountation, HIV related stigma and stress are also key achieved the therapeutic patient healthcare provider relationship in order to enhance care engagements. Coping strategy adopted by the APAIT have very important practical applications, because such strategy determine their quality of life. And also in the end that I want to mention is that a lot of this APA WH also have experienced the migrant smuggling. That is also one of the issues that in the APA-WH populations. These are the references that I got from CDC. Quite interestingly, so the CDC recently changing their websites that are taking out the APA, Asian Americans and Pacific Islander or even Native Americans category out. Just only keep the Latinx and African Americans, but lumped the rest of the population into a big groups. So it's quite interesting. I don't know why the movement go this way, but it's really lacking the information on especially EHE, the End the HIV epidemics, the movements. That's really interesting that those data or analysis have been lacking. So a lot of papers that we have working on about the American dreams and their accountation stress, and also talk about their sleep issues are all here. So in case you are interested about those papers, that you can email me, that I am happy to send it to you. So those data that we work with our Chinese American Planning Council in New York City, and of course APAIT, and the same time that we also work with the San Francisco Community Health Center. It used to be called as a San Francisco Wellness Center. So here are my emails, and then the grants that we got from NIH and sub-grants from the NIMH. Here are my slides, and then it's all my talks. Any questions?
Great. Well, thank you so much, Wei Ti. We are going to now move into our panel discussion and Q&A. So we'll start with some panel discussion on a couple of the topics that participants commonly asked about during registration, and then we'll move into open Q&A. So for participants on the line, feel free to continue submitting questions in the Q&A box as you have them. And also, if there are any questions we can't get to during the time we have during today's session, we'll be sure to follow up with responses to those questions afterwards. So the first question we have that was submitted by multiple participants during registration is, really that, we know there are many differences in the cultural context of the multiple communities that constitute Asian Americans and Pacific Islander Americans. And the question is, what are some unique characteristics of these different communities? So whether it's, East Asian, South Asian, Southeast Asian, or even thinking about individual countries or ethnicities, what are some unique characteristics of these different communities that service providers and public health partners should be aware of when working to reach highly impacted Asian American and Pacific Islander communities in California? So Wei T, maybe we can start with you. What are your thoughts on this question?
I really enjoy the question that it's quite interesting. It really, as a researcher in Asian Americans for a while, it has been really tricky because when we are talking about Asian Americans, especially like if Filipino backgrounds, they do have common last name as Hispanics. A lot of time they are congregate into Latinx, but in fact they are Asian. At the same time, we talk about Pacific Islander in Hawaii. In fact, that 80% of the population are mixed racial, and 80% of them are mixed with Asians. So when you ask them to put themselves into one ethnicity, it's really, really hard. And at the same time, we talk about culturally sensitive care. We talk about how is their personal practice, especially when we talk about individual tailored care. So as a provider, I usually start with that. What is your family situation or environment? We can conclude that most of the Asians are seeing the family is very, very important. So if we want to bring in the family member or disclosure issues, we usually start asking them, what did you do when the family has the big issues? Like, for example, grandpa has a diagnosis with cancer. How did they disclose? That kind of thing that you can predict what might happen about, especially to this kind of situation about HIV. The second time, from our study, we do have study participants or not knowing their HIV status, but from their family member. It's quite interesting because the Asian culture, they don't want to disclose because they want to protect the person who is sick. So it's different kind of perspective. Although there's no article talk about what is the fine line of the disease, whether the cancer is considered severe or COVID considered severe. And that is also quite interesting when we talk about Asian hate. The COVID stigma, not just only from external community, but also internally. A lot of Asian population that they don't even want to disclose they have COVID because it's bring shame into the community. So it's similar to HIV, but because HIV is really contact from sexually transmitted, but COVID is almost everybody. But in Asian community, you don't see them talk about COVID because even though they do get a COVID, they just don't want to talk about it.
Thank you so much. Nan, how about you? Do you want to touch on this question as well?
Yeah, I totally agree with Dr. Chan's feedback. And I think especially on the family side, when I'm seeing client, I tend to be more mindful and ask more follow-up questions when it comes to family. And one interesting observation that I have had is to ask, what's your rank in your siblings? It's a very interesting question to ask for Asian population in general, because a lot of the female, they are the older one and they tend to have a younger brother at home and they have to send money back to China, even though the female herself is making minimum wage here in the US, and that alone opens up so many conversation, like what do you do to manage your stress? So who takes care of you? Do you have the equivalent care as you are providing to your siblings? So I think since the overall Asian culture is very family oriented, however, there are a lot of stigma that comes from family perception as well. So I totally agree with Dr. Chan to ask question, from family, it's a really good building rapport starting point.
Thank you. Thank you so much. Yeah, and I appreciate how both of you really touched on the, common family orientation and just kind of the value and importance of family that both of you have found to be, really important in your own service provision as well across, many communities within Asian and Pacific Islander populations. So I wanted to move to another question, which is, what are some key best practices for engaging Asian American and Pacific Islander communities in HIV-related services? So I know, of course, both of you already shared some great information with us about different effective strategies. But Nan, maybe starting with you, what are maybe one or two best practices that you might like to highlight for partners on the line who are working to engage these populations in HIV-related services?
Yeah, definitely. I think the trauma-informed lens is very beneficial when we serve API population at the intersection with HIV services, and we sometimes we have to be very mindful. When we have an Asian client in the waiting room, that we may have to come closer to them and call them in and bring them in. And I have clients that they're so scared of taking transportation because of this whole, Asian hate crime, that they would ask me if I could walk them down and see them get onto their Uber. So I think it's really to see them as, individual experiencing all the chaos and all the COVID-related hate and their each individual experience. And by the end of the day, I felt like that's no difference when we think about African-American community, when we think about other race ethnicities. I think is to really treat people with care and to see them as a whole person, not only a person or a client or patient with HIV-related need.
Thank you. Dr. Chen, how about for you? What maybe one or two best practices would you want to highlight for partners on the line who are really working to better engage these communities in HIV-related care?
It's for all the agencies that have been in contact with that, in fact, that they are really looking for the funding to support them to do the street fair, or to focus is more on the Asian Americans that even PrEP. So it's quite interesting because that the government is not really seeing the Asian Americans severities is in this HIV related issues. A lot of them, they are giving me feedbacks that because there is no data, then the data shows only maybe 2% or 3% in CDC statistics, that why they need to give the money to Asian American. So that means that a lot of them are not really focuses at all, and even EHE are not geared toward Asian Americans. So working on the research publications, and then that is how I convinced them that it's quite interesting if we are publishing some paper in the scientific world or academic world, that at least you can use these papers to convince the funder to give you some money. So those fundings are very limited. At the same time, they need to use some other social services in order to contribute to HIV care fundings. So it's quite interesting that how to see these things. And second thing is that, especially in New York City, when they do when the Department of Health doing the advertising for like a COVID testing or COVID vaccine, a lot of time that Asian populations are not geared toward targeted. So those people who are not acculturated to the community, so are not even focused. So yes, maybe Asian Chinese language might be one of the target, but not that all the language will be targeted. For example, like Burmese or Malaysians, those local languages are not rarely seen or like a Thai language. So it's quite interesting that when we see how we target the Asian population, we just only selected a few of them.
Thank you so much. And I appreciate, I think you really touched on some kind of broader policy or kind of funding level interventions that are needed to kind of help support this work, and the need for more data in order to drive that funding to support this work as well. So thank you for that. Before we move into open Q&A, I'd like to ask one more question of both of you that came up during registration. This question is, in what ways do you see mental health intersect with HIV in Asian American and Pacific Islander American communities? And are there any effective approaches to address this intersection? So of course, both of you touched on this a bit during your presentations, but Wei-Ti, can you say a little more about what you've observed in terms of the intersection of mental health and HIV in these communities, and then, any possible strategies to address this intersection?
Yeah, it's a good question, because I would say most of the Asian American population in the States, they don't even want to mention anything about mental health, because when you think about psychiatric care or going to the psych doctor, it means that you are weak. So mostly in Asian population, when they are having some issues, it presented with diarrhea or somatic issues, more, for example, headaches or stomach ache. So when we giving our HIV diagnosis, a lot of time we usually have a language ability, social work or psychologists on site to make sure that they are there to provide support. What the studies have, what we have been working on is that usually the first year of the HIV diagnosis is the most needed time. So within a year of the diagnosis, the most critical is about 6 months. So usually we have every 2 weeks of follow-up, like a phone call for every 2 weeks until like 6 months, and then release them. So usually the case management is quite important and help them to get into the care system. So mental health are quite critical during the first 6 months. At the same time, the mental health providing to the positive person is not enough. We also need to include at least one of their significant others, whether their spouse or their partners or their children. It's quite important. We need to make sure the person is willing to disclose, and then help the person to disclose. So usually our experience is that after we identify the person and the individual, the people who are HIV positive is willing to us to help him or her to disclose, then we will make it happen. And then so make sure that the person has somebody, a family member or a close friend can monitor them. So peer support, it's possible, but might not be that usable in Asian populations. Our experience is that they don't want anybody in their family, their friends network to know about it, even though they already know each other on the street, especially in the infectious disease clinics, waiting room, they are not even say hi to their friends. So it's quite interesting. So when we design a study design for any intervention with HIV positive Asian population, we don't do focus group, because that is not the time they're gonna talk. Yes.
Thank you so much. Nan, how about for you? Can you just say a little more about what you've observed in terms of the intersection of mental health and HIV in these communities and possible strategies to address this intersection?
Yeah, definitely. It's quite interesting. Dr. Chen mentioned the lobby situation, and that's totally true. That's totally true. We have clients know each other and come to our group, and they would not talk to each other, but they would have a really nice conversation in that group setting. But even that takes time to build the rapport, to trust each other, and to remind them about the confidentiality. And believe it or not, for us, it's very comfortable to say confidentiality, but it took me a moment to find a Chinese word to explain to the population the confidentiality and what is HIPAA. to our client. Because in Chinese culture, you know, we have a different understanding of confidentiality. We have a different understanding of what is privacy. So that alone, it's a you know, building rapport part, you know, trying to understand, you know, what is privacy, what is confidentiality for API individuals. And that goes with both HIV and mental health services. And for me, I think it benefit me a lot when we do mental health services. We change the wording a little bit. We may not necessarily say, oh, this is a therapy session. We may not necessarily say, but as time goes by, when they, again, build the trust with you as a service provider, they started to share with you. For me, sometimes I start, even though I'm a therapist, I started, you know, with my Asian client, where can they have like English classes? You know, those things like how help them make a Uber appointment, those case management things, it's really sometimes bring you some like rewarding moment. And that's something, the stepping stone for people to share the emotional side.
Thank you. So now we'll move into some open Q&A. We got a few different questions about acronyms. So, you know, AAPI versus API versus APA. This is something for which there may, of course, be lots of different perspectives. But the questions are kind of, can you help clarify or elucidate a little bit of these different acronyms, and, you know, when folks should consider each one in order to be most respectful? And this is a question for either or both of you.
Yeah, I would say that usually we don't talk to the populations as API or AAPI, or it's in the clinic setting. It's quite interesting because we don't identify as that. Or did you see yourself as an API or AAPI? It's quite interesting that even though Filipinos, we see them as Asian Americans. A lot of the time, they see themselves as Pacific Islanders. So it's really hard to define where you came from and how you came from. Or if you see Taiwanese, that a lot of times some of them will see themselves as a Pacific Islander, and some of them will see themselves as Asian Americans. So it's not that clear cut. And especially that I mentioned that Hawaiian, it's really hard to put them as Asian or API, or that it might be the reason why we lumped all of them, that APA or API or APA. So it's kind of like we don't see them as a big population. I would say this kind of terminology usually uses in the public health. But in clinic settings, we just see them as where you came from and how you want me to address you. So it's more how we see them. And at the same time that, for example, we will just lump all the Hispanic background as Latinx. But at the same time in clinic, we will see that where you came from as a Puerto Ricos or from Mexico. It's really individual care. So I would say it's really hard to give definition. It really depends on where you are working as a clinicians or working as in public health.
Thank you. Anything to add, Nan?
No, I think that captures all the information.
Okay, great. Nan, this is a quick question for you that came in. Do you provide therapy for people with Medi-Cal or just people without insurance at all?
We do both. We primarily serve people with Medi-Cal insurance, but we also have programs, especially if you are HIV positive. We have Red and White, which is a mental health services for people who do not have insurance.
Great, thank you. For Dr. Chen, this question came in. Do you think the existing AAPI service groups adequately meet the needs of the community, particularly in the area of HIV/AIDS? So are there enough service groups and resources available to meet the current needs?
Well, from my experience is talking to those agencies, or none of them really think that they have enough funding to run all the services. So especially in tri-state New York City areas, that it's quite interesting. A lot of populations are HIV positive are travel from South Carolina or North Carolina for 4 hours to bus in order to get cured in New York City downtown, because of the language issue, also because they don't want to disclose to anybody. So there are some tricky situations that I believe that also in Los Angeles, a lot of people came from Arizona or nearby states in order to get the care. If their acculturations are not good enough, they of course need to transport it to services where they can have their needs from. But at the same time, for those who are highly acculturated Asian Americans who are HIV positive, they usually can find local agencies that doesn't really focuses on Asian Americans to have the care. So really depends on how the country, the government, or the policy makers that see the importance of the HIV care in Asian Americans, especially for those who are newly immigrants. That it will be the key issues for policymakers to think about, or stakeholders to think about. Yeah.
Thank you. So this is a question for both of you. Our participant says, I know that confidentiality is an issue and it's often linked to stigma. What is being done to minimize the stigma within the different communities that make up Asian and Pacific Islander Americans? So Nan, maybe starting with you, what have you seen maybe in your own organization or even other organizations being done to minimize the stigma within these different communities around HIV?
I think within our conversation, we have a specific position called community liaison, and she serves as, of course, the community liaison and provide cultural competency training to different organizations. We provided various training like, LGBTQ 101, like we also share like mental health in Asian culture and how do we address mental health in a crisis situation. We have been providing those kind of trainings to different community members. And we invite guest speakers, and recently we have been trying a very creative, and this is something that my director has bring in the new idea, is to provide self-defense class to all the staff and all the client. So we have been doing that beginning February, and everyone had a 4 hour, almost 5 hours self-defense class, and it's such an empowering experience, and it's very useful. I mean, I hope no one uses it, but it's very useful that if there's anything happen, we at least know how to react to a crisis situation, especially being an Asian female here in Los Angeles. I'm always on the alert when I'm like walking on the street, and I can only imagine if any like API individuals, experiencing the stigma and also having HIV. So, we have been, doing our own learning, even though we are, my division director is Asian as well, but we're still learning different community, different Asian, and we recognize the space that we have to grow, and then we start from there. And, and I'm very happy outside of our organization, we have so many representation like Dr. Chen on the research side, and, we have so many authors, coming up, growing up in HMart is such a popular book. And we have another author, she writes about schizophrenia as an Asian female. So there are so many things that it's not under the spotlight exactly, but it's there, and it's there for us to learn, to take advantage of it. And of course, we have social media. You know, it has the bad side of it, but you know, we have additional outreach platform because we have social media. So, you know, I'm happy there's a shift, there's a movement within our community, and it's a long way to go, I think.
Yeah,
Thank you.
I would say is that from my experiences with these agencies is quite interesting. The community work is quite important in order to decrease the stigma, especially, for example, like a temple gathering. If they can have one of the people inside members who has a medical background, who is willing to spend like a 10-20 minutes to talk about healthcare, for example, cancer prevention or HIV prevention. That is the chance that they people who are inside a meeting or gathering can know about what is that means, especially in this time that about COVID or HIV or cancer prevention. Those healthcare providers are the key person to change the ideas of those basic information and providing the answers for those people who might stigmatize those disease. The second thing is that we are trying to target the second generations who are educated in the United States. They usually have less stigmatized about those disease. We can use those second generation and go back home to talk to their parents about what does that mean and what the community means and how to do the preventions. That is because that will be one of the places that starting points. So when those parents who are seeing people who are HIV positive, they are not that afraid of talking to them. They are not that afraid of the people who are COVID positive, or make sure that that vaccine is correct. So using the community grassroots and delivering the information is also important.
Great, thank you so much. I have one more question here for both of you, which is, are there any recommendations for reaching out to faith-based communities and advocating and supporting Asian American and Pacific Islanders who have or are at risk for or are potentially even living with loved ones who have HIV or AIDS? And the participant added a comment: many priority populations, for example, Filipinos and Samoans, have strong ties to their faith-based communities, and quite a bit of decision-making and support happens at this level. And they also added, thank you both for all the work you do. So are there recommendations for reaching out to faith-based communities that each of you can touch on? Maybe starting with Nan?
Yeah, with full transparency, I'm not really familiar with faith-based organization. But I do know there are like plenty of faith-based organization here in Los Angeles, and that's a luxury. Like I felt like we do not have that in, I don't know, North Carolina. So I refer my client to Tsuji. It's a Buddhism-based organization, and they have very affordable dental care and other medical services as well. So that has been one of the major resources that I refer to client. And also, I could be wrong because I'm not really familiar with religion. Each Asian community have different perception about their faith, and not every Asian resident city is open about their faith in the beginning. And I find this is something that is very different from a Caucasian population, or even people who practice Christianity. A lot of Asian faith-based Asian people are now that some are now that, you know, open about discussing that it's a privacy issue.
Yeah, so I just want to add in fact, that just like my slides mentioned, that Christianity is there are some judgmental issues inside. So it depends on whether the person in charge of the church are willing to open up or buy in on this kind of topics in their daily talks, it will be very hard. But usually Buddhism or temple goers are more likely to open up their doors to share those informations. So it really depends on the one in charge of the religious practice place. So it depends on whether they are willing to work with providers, or the best thing is their member inside who has healthcare backgrounds are willing to help out to do this kind of delivery will be much easier as outsider that just jump into the clinics and then talk about HIV prevention, what does HIV means. So usually they gathering like once a week, and usually does have a 30 minutes breaks that it will be the best time for those people to share information.
And one of the outreach strategy that we have been finding very efficient is to reach out to have flyers in those grocery stores in San Gabriel Valley, like 99 Ranch. Those are a very friendly environments. People tend to have less guarded because it's a grocery store. So that's one of the outreach activities, outreach place that we find efficient.
Or maybe bubble tea spot.
Yeah, thank you. I love that, really thinking. I mean, this is something I know many of our partners on the line are working to do, thinking about those kind of community spaces that are well-traveled and trusted, that can be potentially also useful for kind of starting that conversation, or, beginning to plant the seed for engagement and care. So I love those suggestions as well. So we're in our last 8 minutes now, and I wanted to kind of close by asking each of you if you have any other kind of words of wisdom or recommendations that you want to share with folks on the line on this topic of, how do we address the HIV epidemic in Asian American and Pacific Islander communities here in California. So I'll start with you, Nan. Any kind of final words that you want to share with folks or recommendations?
I think, like my last slide mentioned, every 1,000 miles start from the small step. I think every small step matters, and change your demographic chart, make Asian, they're like fine, so we can check it off. And if you are doing social media outreach, do you include Asian people on your presentation? And those are very warming things, and they're small. And also I like what you did in the morning, Elena. It's very warm. It's, did I pronounce your name right? Can you help me? And those are things that they're so small. And for me, I felt like sometimes we don't have to go to that, identity politics, like, oh, if you're, supporting Asian, if you do this and that, like stop Asian hate, it's, by the end of the day, I'm a true believer, like, how do you want to be treated? Then treat the people the way you want to be treated. And I think one thing is Asian people have accent, and, are you comfortable with addressing, like, maybe have an opening line, like, hey, I may ask you to repeat yourself. Do you mind that? Small things like that, I think, has a very big impact on Asian community. I remember when I first come to this country 15 years ago, having a doctor telling me, oh, do you mind repeat this? I'm sorry, I couldn't understand it, instead of like correcting my accent. And that's a different way of approaching it. So I think for me, it's always the small things. It's always treating people like you want, how you want to be treated. That goes a long way.
Yeah, so I just want to use my minutes to talk about, yes, so far that I mentioned that Asian Americans or Pacific Islanders are one of the hardest to reach populations. So in case that you are really interested about the future projects, that I think that we can work on the research project or even service projects that SAMHSA will support. That we can work on the training and then outreach to those populations or the key things that we can work, especially in Northern California or Southern California, that we can work on together. And even in Hawaii, that there are a bigger populations of Asian Americans and Pacific Islanders. Yeah.
Great. Well, thank you both so much. For everyone on the line, I will send out the slides and contact information for our amazing panelists as well if you have additional questions. But I do want to thank you both again so much for sharing your amazing work and experiences and insight with all of us today. And also all of our attendees, thank you so much for your great participation and questions. Please do look out for a follow-up email from me with relevant information from today's session and also a link to our quick evaluation form. And I also wanted to remind folks that the recording and slides from today's session will be posted on our website by early next week. So thank you all so much again and have a great afternoon.
Thank you.